Thank you so much for having me. It's an absolute honor to present my best coronary case of the year. I'm an interventional cardiologist in New Jersey, and I have found a home to perform my high-risk procedures at Mount Sinai. I'm going to present to you a case of an uncrossable angulated RCA. My patient's a 59-year-old female. She's morbidly obese, hypertensive. She has known coronary artery disease, was previously revascularized to her LAD, and had a known lesion in her RCA that had been intervened upon, but it was unsuccessful. And she presented with worsening symptoms, both chest pain and dyspnea at rest, CCS class 3. And this is her left coronary system, and what you can appreciate in this caudal view as well as this cranial view is that her LAD system's intact and that the circ is intact and her LAD stent is widely patent. But her right coronary system is very tortuous, it's angulated, heavily calcified, and there's a total occlusion here in this RAO view that's really subtotal, almost TO'd in nature with good TIMI3 flow, but slow. So it's a very complex lesion. I performed this in New Jersey and took a step back and brought the patient to Sinai. And I think when I looked at the lesion, it was complex. It was severely tortuous, heavily calcified, angulated, and I knew that I was going to need certain crossing strategies, whether it was Guideliner, support microcatheter, a CTO toolbox, as well as a plaque modification technique for that degree of calcium. So we could stop there, but I could talk, at least let me show you what we planned for, because we knew we were going to intervene on the right. So here we are with the 6 French system, AL 0.75 guide. There's a fielder wire that's negotiating the proximal vessel and a fine cross that's waiting in the guide, ready to go. And what you can appreciate in the next field, in the next views, as we tried to advance the fine cross, it wouldn't negotiate the proximal lesion, and the guide is kicking back. So then we tried a Guideliner to give the fine cross more pushability. The fielder wire here is placed in the marginal, but what you can see is this was also unsuccessful. Both Guideliner and guide catheter are pushing back, and the fine cross is unable to negotiate this proximal segment. So taking a step back now, what are our options for antegrade crossing? Dr. Parikh, should we open it up to the panel here?
Yeah, so Gautam, how do you manage this case now? You've got this sort of awkward shepherd's foot calcified right with a sort of an aneurysmal plaque to one side. Clearly the wire is preferentially in the acute marginal branch and nothing else will grow, and you cannot navigate a wire distally to get further purchase. They've tried, now you've got good guide support and you've got a Guideliner, both of which have failed. Granted, the fine cross may not be the lowest profile, but what's next?
So yeah, Manish, thank you. I wasn't terribly happy with the choice of the fine cross. I mean, there are probably better microcatheters that might help. We'll grant that. One option might be to leave this wire there and come with a different system, different wire, different microcatheter, leaving this there to then try. You could try an anchor balloon technique in that marginal where it is. That would be another option. Finally, you may have to separate it and consider atherectomy of the proximal segment separately from the rest of the vessel. That may be another option as well.
So the anchor balloon isn't going to work here because you're not able to get a fine cross down on this vessel. You might be able to anchor on that conus branch up high up. That might be an option, but again, Sheila's chosen a 6 French system here, right? Okay, so again, so here, see a case like this, where it doesn't matter radial or femoral, you're going to need support. 6 French may work, but when it doesn't work, you're hoping for a bigger guide system. So, Dmitry, what are the other tips and tricks or options here?
Yeah, I think your point is very well taken. I think this is something that failed before, and going into this, you have to really go in, be ready for battle. So I think, either doing it 7 French radial, or potentially doing it as a femoral 7 or even 8, but 7 French probably would have been a potential solution with a Amplat's guide.
Okay, so let's talk a little bit about microcatheters. So Gautam mentioned fine cross. So we've got a whole host of microcatheters to choose from. I mean, there's 10 of them, okay? And your lab will not have all 10, and nor should they. But if you're going to do this, you need to have the lowest profile microcatheter, and there's a couple. The Turnpike LP is very, very good. The Corsair is very, very good. There's a Corsair Gold. And then there's also a lower profile than that, which doesn't have much push. But here I would have tried a Turnpike LP that could spin so that I could navigate that turn and then try to redirect my wire. The whole point here is to get the wire down the vertical part of the right and over. And once you do that, you'll be able to manage this right coronary. So it's the calcium and the tortuosity that's defeating you here. So, you know, with everything else that was said by Gautam and Dmitriy, that's the only other thing I would have tried, being a different system. Failure of fine cross doesn't mean that other microcatheters will fail.
I agree. Turnpike LP would have been a great choice for the torque in this angulation. The technique that was chosen, there were a few options, as you've heard from our panel. The technique that was chosen was definitely a strength of the institution that I was performing the case at. And so a very high-risk approach. The fielder wire was exchanged for a rotofloppy. It remained in the RV marginal. And we went with a 125 burr and performed a short run of plaque modification for about 4 runs at 150 RPMs with the 125 burr. And this was our post-rotational atherectomy image. As you can see, there's slow flow down the vessel. And then in a parallel fashion, we advanced our fielder wire to allow for balloon angioplasty. And you can see we're still struggling at advancing this 2.0 by 12 balloon, but we were able to perform serial dilations of the proximal lesion. Post-balloon angioplasty, we had a contained dissection and poor antegrade flow. And we don't have a wire down the antegrade vessel. We don't have an antegrade wire down the vessel. Next, we went with a supercross, and for its success being a microcatheter in angulated vessels, and placed a Gaia second coronary wire that successfully went down the vessel into the distal segment. We exchanged, now our fine cross was able to advance over the proximal lesion into the distal vessel. We exchanged for a workhorse wire, performed serial balloon dilations with Guideliner support, using both compliant and semi-compliant balloons. And our stent placement was assisted with balloon-assisted tracking for stent delivery using a Guidezilla. And we were able to successfully place 2 long, large drug-eluting stents. And this was our final result. And some quick follow-up on the patient's done very well. It's about 8 weeks since the procedure and no longer having chest pain at rest or shortness of breath, but still quite sedentary. So just putting everything together, the crossing strategies that were used were rotational atherectomy to negotiate the proximal RCA lesion, a supercross microcatheter to negotiate the angulation, a Gaia second wire, and balloon-assisted tracking for stent delivery. I think that the take-home points are that there are many ways to approach a complex lesion like this that's calcified, angulated, tortuous. Systematic algorithmic thinking can be modified in the face of complex anatomy. Definitely the route that was chosen was extremely high risk and had a high chance of acute vessel closure. It was performed at a center that was going to be comfortable and prepared with the inability to open the vessel, and hemodynamic support was available. Thank you.
It's a very, very nice case. Many ways to do this. The supercross comes in several different angles, 120 degree being the most angulated, and it actually sits in the vessel angulated so that you could actually direct your wire when no other wire goes. There's a lot of other tips and tricks that could have been utilized here, but you know, essentially the key of what Sheila did beautifully is sort of progress through this case step by step. And you know, doing roto without a wire all the way distal is a little bit gutsy. Don't do this at home, but you were able to get away with it. So very, very nice.